Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, I am joined by my buddy, Sarah Krager, ED doc and intensivist, to discuss various questions that have been sent in. I thought it would be fun to get Sarah to join me and answer the questions with me. We talk hemodynamics and a lot of other stuff. Before we get there, super quick, we have maybe 8 tickets left for the Reanimate ECMO conference happening in November in San Diego. If you want to get tickets, now is the time. It's going to get sold out, and then you're going to complain, and I'm going to be like, I told you. And then we have just a little bit of time before the Unburnable Flourishing course, a course on becoming burnout proof. If you're interested in that, check it out at unburnablecourse.com. And if you check the mailing list, we sent out a big discount for the next 4 days, so you should really get on that. And the Reanimate course is reanimateconference.com. All right, let's get in. Sarah Krager and I doing EMCrit question and answers. Sarah Krager, who are you and what do you do for anyone who hasn't heard your earlier lectures on EMCrit or seen you on the speaking circuit?
Hey everybody. So I am an emergency physician and intensivist, and these days I mostly work in the ICU. So I do cardiothoracic ICU, and then I do this awesome community mixed med surg ICU where I feel like an idiot every single day because every single day I see stuff I've never even heard of before. And then on top of that, I do a lot of medical education stuff.
Yes, you do. All right, Sarah, you've heard some of the hemodynamic podcasts we've been putting on EMCrit lately. I want to hear your approach. We actually featured one of your papers on one of those episodes, but I want to hear where you stand in 2026. You have a patient with undifferentiated shock. We'll even give you hypotension, and you're evaluating them at the bedside. What are you actually doing versus what we pretend we do when we're giving echo workshops and such? What are you actually down and dirty doing?
Totally, because I think there's this big disconnect between what I learned in ICU fellowship and if I'm giving a lecture on shock, what I'm going to tell people. Then you go to the bedside and they're like, give fluids and antibiotics and call it a day. And there's this huge disconnect, and I think that there just has to be something in between. That being said, I also think a lot of people are like, sometimes they're just bleeding to death, and sometimes they are just bleeding to death. And that's why I think it's oversimplifying to say we should use one model. I actually kind of see this as a gear shifting up, because the way to think about shock is not so much a yes-no diagnosis. I think it's a process of iterative hypothesis testing. And sometimes that process leads you to, yes, they're bleeding to death, let's not overcomplicate this, but other times it doesn't. And this is one of those things, I can say that and it sounds great, but what do I actually mean by that? So the model of shock that I like to talk about in the specific paper that I wrote, it's basically a mental model with, like you need with any good mental model, a systemic way of applying it at the bedside. So the core of the mental model is the idea that we should not be framing shock around blood pressure or lactate, God forbid, but that we should be framing shock both in the way we think about working it up and treating it around identifying and correcting problems with forward flow. And forward flow and forward pressure are not the same thing, because forward pressure, that's great. That is something that contributes, but the way to think about forward flow is it's actually a vector sum of competing forward, backward, and external pressures. Now, that's a lovely mental model, but how do I apply it at the bedside? I actually literally draw a map where I map this vector sum onto a simplified representation of the circulatory system. And what I'm trying to do is create a framework that allows me to translate clinical data, ultrasound data, into hypotheses about the things contributing to hypoperfusion in this individual patient. And what I found is that it allows me to work through some of these more complex shock states, but also to recognize that it would be nice if every single patient was due to one big reason, and that's why they're in shock. Call it a day, done. And sometimes that's the case, but a lot of the time it's not. Sometimes might have been a perfect storm of a bunch of small things. Or sometimes it did start with one big thing, but then that precipitated a whole bunch of other things. And the more we do to the patient, the longer they get in their ICU course, the more procedures and events and interventions and things we did to them, the more things that can go wrong. So it's a way of mapping this forward flow model somewhere that you can actually use it, write down, map your patient onto it, and then just on paper, work through what's wrong with them, what interventions do I need, and then keep it with you so that as more things go wrong, as they decompensate for another reason, as you're like, oh, I tried this, just kidding, that really didn't work. I need to try something else. You can keep track of it and improve upon it in an organized way. So that is the overall idea with the way that I like to approach shock.
And we'll put one of your diagrams in the show notes so people could see what you're talking about. You've also told me that and you mentioned this just briefly at the beginning of that you gear up, and that a patient is crashing in front of you, you very well might use just pumps, pipe, and tank, and then get more involved as you get more stabilization and time to think. Tell me a little bit about that, Sarah.
Yeah, so I think when I'm listening to podcasts or even reading these two papers, it's tempting to say, which one of these models do you like to use? But instead, I think we need to recognize all of them are simply mental models. They're heuristics that we can use at the bedside. And I actually find the pipes, pump, tank, or sort of rush exam style versus this, what I call the 3 pressures mental model paper that I wrote, versus the 4 interfaces model as simply complementary things, with the idea being understanding all of them will allow you to make this cognitive transition to progressively higher gears based on the situation you're in. So what phase of the resuscitation in? Did this patient just come in super sick and you have no idea what's going on? Also, how complex is this patient? Is this a patient who was in septic shock and then they had a massive PE and then they got a tension pneumo from my line that I just put in? And also, realistically, your own cognitive load. If I just got 7 ED admissions and 3 of them are coding, now is maybe not the time for me to be doing Vexis on every single patient. So both where is the patient at, where is my resuscitation at, and where am I at? And so I break this down into 3 gears, understanding that the lower gears are sacrificing physiologic nuance for functionality and accessibility, and then that balance is going to change as you shift up into the higher gears. So the first gear is just pipes, pump, tank, right? Like your basic core categories of shock. And I do this like first pass assessment, the initial patient, or with an acutely deteriorating patient, or if my patient's actively coding or peri-coding. Because I'm here trying to be like, okay, I need to not miss big things I need to do something about immediately. If they have a bunch of blood in their belly and I need to call a surgeon, I need to not miss that right now. If they have a massive tension pneumothorax, I need to not miss that right now. So it's my first pass. Let's make sure they're not actively dying from one big thing, and I'm not sitting there like drawing a map and thinking really hard while my patient needs a chest tube. So that's first gear, pipes, pump, tank. Then I'm going to move on to second gear. And second gear is this sort of 3 pressures, competing pressures model. And I go up to this gear when one of a couple things happen. One, my patient is maybe just not fitting cleanly into a single box, either what's going on clinically, their labs, the ultrasound assessment I've done so far, or maybe they're just not getting better. I identified a problem. I thought I fixed it. I did the right things, and they're not getting better, or maybe they're getting worse. This is when I start sitting down and using my 3 pressures map to systematically think through all the different factors that might be contributing to their shock physiology. And I'm now at a point where I have the cognitive bandwidth to do this because I'm not worrying that, oops, I need to be calling the surgeon. So I have a little bit more space. Then we shift up into third gear. And that's really the sort of 4 hemodynamic interfaces model. And I'm now at a point where I've gone through my 3 pressures model. And we even talk about the beginning of that interfaces paper, that paper is assuming that you are starting at a point that you either have source control, meaning that you've identified and addressed any big pathophysiology that requires specific treatment. That's any kind of mechanical issue that you've already thought of and addressed that. That's where that paper is starting in the first place. And now that I've done that, I've gone through all my big causes, and I'm sitting down in the ICU and I'm like, they're just smoldering. I still haven't quite got it right. Things are not clearing. They're still not looking good. Now I can really sit down and fine tune this and deep dive my patient's phenotype of their individual shock physiology and really try and mess with and optimize my strategy for fluid management and vasoactives. And it's not an accident that I think about these things on the same map. It's like painting a picture, right? You start with a general sketch, then you add a layer, you add a layer, you add a layer. What you wouldn't do is start with a super detailed corner of the painting, do every detail in that corner, and then move on on to the next corner. That's not what you do. So this is the idea, that you're shifting your brain up into gear, layering it on so that you can deal with all kinds of patient complexity and all kinds of patient situations, and you have those cognitive options.
I love that analogy, and I think it's so apt because I think people who are ignorant of how painters paint think they just roll up to the canvas and put their masterpiece on in one shot. But when you actually watch the process, it's so interesting because they just sketch it out in pencil, as you mentioned, and then they might do some preliminary, very rough outlines, and it just keeps getting built up in an iterative fashion. And that's exactly what you laid out. So I think that's fantastic. One of the questions that came in from a listener actually fits into with this quite nicely. Simone writes in, I'm repeatedly wondering about a specific scenario, the edematous patient that appears to be hypovolemic during POCUS assessment. I know clever docs treating the situation with fluids along with diuretics, but this approach doesn't make much sense to me. What do you think? Is there a clinical scenario in resuscitation which mandates fluids and diuretics, except for maybe rhabdomyolysis, and then also asks about albumin? So what do you have to think about this, Sarah?
Yeah, I think this is a great question. This comes up all the time. And one of my pet peeves is people giving fluids and diuretics at the same time if they don't have a really good reason. Now, of course, there are good reasons for this. And she named one, which is rhabdo. And that's an example of a time that you are not trying to adjust a patient's total fluid balance. You are, in that case, just trying to flush the kidneys and make sure things don't precipitate in the kidneys. Another time that it makes sense is if you have an electrolyte derangement, like if you're hyperkalemic, right? That's another case. You are not trying to adjust their total body fluid balance. What you're trying to do is fix the hyperkalemia, the hypercalcemia. And so I think you have to separate in your head somebody's total body fluid balance from the composition of their intravascular space. But what she, I think, is specifically talking about is the situation where you do believe you want to achieve a net negative fluid balance. Now, I think the first thing is just why do we think that they're hypervolemic versus hypovolemic on echo? And I think this can be very tricky. And one of my other favorite rants to go on is the sort of physiologic differential diagnosis of echo, because I think people often, what they mean when they say that is the left ventricle looks hyperdynamic. Now, the left ventricle may be hyperdynamic because you're hypovolemic, but it might be hyperdynamic because you're vasoplegic. Or what if your RV is failing and the LV just doesn't have anything to work with? Or what if you have wide open MR or AI? So I think the very first thing I would do in that situation is make sure I actually believe it's the case that my patient actually needs volume off, and that this will help them either because it'll improve their hemodynamics and improve their forward flow, or, and this I think is more the situation she's getting at, their total body fluid overloaded. So I walk in, their chest x-ray is puffy, the patient is puffy. I'm like, I can't even see your feet because there's so much edema. You can't put in a femoral line because you have 6 centimeters of edematous tissue, but they look intravascularly dry. And that is a really tricky situation. And I think the answer is it depends. In order for me to try and do a push-pull strategy where I'm saying I'm trying to use albumin to pull fluid from the extravascular space to the intravascular space, then once it's in the intravascular space, then I can try and pull it off their body. That's a physiologically reasonable thing to do because you can't diurese fluid directly from the extravascular space. That's not how this works, nor are your kidneys going to respond to your extravascular fluid status. They respond to your intravascular fluid status. So it can be hard both hemodynamically because they start getting hypotensive, but also just the kidneys may not respond to the diuretic. So in that situation, what do I do after I've made sure I actually think that they need fluid off? The first thing is to say, are they vasoplegic? Because this can be a big thing. And if you have all of your fluid sitting in your unstressed space, and a lot of these patients, like for example, the cirrhotics, the chronic critically ill patients, the patients with poor nutritional status, they may also be vasoplegic. So I will start some pressors on them, not high dose, but low enough dose that I think I'm getting everything vasoconstricted enough that I'm converting my unstressed volume to stressed volume, because volume in the circulatory space that's not stressed is not usable. And then if I think they have a nutritional deficiency, especially if I check their albumin and it's less than certainly 2 or less than 2.5, this is something I will do. Now, the data for this, I will tell you, is not strong. And you can make a really great argument that in an inflammatory state, in septic shock, what you're actually doing is probably hurting them because all that albumin leaks out and you've just been counterproductive. So in a state like sepsis, where I think they're acutely inflamed in vasodilatory shock, I'm not going to do that. I'm going to try and fix the problem, and I'm going to start some pressors. Now, in a patient who's been in the ICU for a while, maybe they're a bad cirrhotic, maybe they just have awful nutritional status, sometimes I will try and do this if their albumin's really low. But the catch is the timing. Because if you give them albumin, that's great. That albumin is going to leak out of the intravascular space at some point. So I find this much easier to do with CRRT, because with Lasix and diuretics, it's really hard to adjust the timing. I can give them albumin, pull things into the intravascular space, and then by the time the Lasix works, it's now all leaked out. So I like to do it on CRRT sometimes. And I'll give them a bolus, and I like 25% albumin, and then I start pulling immediately, start pulling right away. You can try it with patients with Lasix and albumin. You can try it. And I use 25% just because if I'm going to do this, what I don't actually want to do is be like, oops, that didn't work. I gave them 7 liters of albumin and I still didn't get any fluid off. So I want to give 25% because I want to give a small amount. So if it doesn't work, I haven't shot myself in the foot. Data-wise, there have been a couple of studies on this. One of them suggested that maybe if their albumin's really low, it may help getting fluid off, but I just want to note quickly, nephrologists do this all the time. Take a look at their dialysis orders at some point. You know what they all write for? Every nephrologist I've ever met writes for PRN is as they're pulling fluid off the patient, if they get hypotensive, give albumin. So the nephrologists clearly, at least on some level, do believe in this. So it's something I'll do. But I think, like anything else, it's not a never do it, always do it. It's a be thoughtful. And if you've thought through it and it makes sense, it's a reasonable thing to try out in the right patient.
It makes for a more interesting podcast if I could disagree with you. But
Love
unfortunately, I can't
Oh.
find anything.
I thought you were disagreeing with me on this one.
No, I wish I could,
albumin
but
rant.
I got nothing. As you're saying the words, I'm like, oh shit, I can't say that now. I can't say that now because you've gotten all the points I want to hit. So I'll just emphasize just the one that I think is most critical, which is, look, I only do resuscitative critical care. So I don't see them in their phase when I actually start wanting to de-resuscitate them. So for me, if you're going to convince me to give a diuretic and fluid at the same time in the resuscitative phase, you really have to convince me hard that's a good idea. Every time I've been told that's a clever idea, it's been exactly as you say. That patient's actually been vasoplegic and edematous. And what they need is vasopressors. And then we could work with the edema. We could decide whether it's worthwhile to give some diuretics. And that the forbidden act of diuresing an active shock patient, it's not forbidden anymore. You could do that. But I don't think it's clever to give fluids and diuresis during the resuscitative phase of a patient's care. Really ask yourself if what they actually don't need is diuretics plus norepinephrine rather than diuretics plus fluid in that resuscitative phase.
And I would even say not just that it's becoming, I guess we can give diuretics during the resuscitation phase. That's, I think, where we're at. But I think where it should be is sometimes you need to give diuretics during the resuscitation phase. And I think, and that's part of what I like to talk about with this 3 competing pressures thing, that if one of the major reasons your patient is not perfusing is the back pressure, is because you have too much fluid in the system. It's causing a back pressure at the level of the capillaries, so they're all congested, they're not getting perfused, and it is not helping the mechanics of your left ventricle or your right ventricle, certainly for that matter. Then sometimes the only way to fix their hemodynamics during acute resuscitation situation is to actually give them diuretics and get volume off them. So I think we all need to really internalize that it's not just the forward pressure. If you think about the back and external pressures as well, then sometimes you have to give diuretics during an acute resuscitation phase, and that will actually improve your hemodynamics.
Absolutely. All right. We've gotten a question about the treatment of lactic acidosis. This is from Christopher. Hey, Scott, I have a clinical question. I'm a big fan and know you could explain this well. I'm a flight paramedic in Eastern Tennessee, and I recently had a debate about LR and lactic acidosis. I've been taught that LR is better than NS, but it was brought to my attention that on each bag of LR, no matter what brand, it states not for use in the treatment of lactic acidosis. I was wondering if you could explain this better. Why would the packaging say that? And would this change your standard of care for people with elevated lactates? All right, Sarah, you want to start off?
Okay. I'm clearly very triggered by this question. What I would like to propose is we write a petition to the manufacturers of LR and tell them to take that off their packaging immediately. So here's the deal. When I think about elevated lactate, to me, there's three possible ways this could be happening. One is a lactic acidosis due to hypoperfusion. That is a bad thing. That is a thing that I want to fix. And the way to fix that is not giving bicarb. It may be giving fluids, but it may not. It may be giving diuretics. It may not. The way to fix that is to do whatever you need to do to improve the patient's perfusion. So lactic acidosis due to hypoperfusion. The second kind that you're going to get that we'll talk about, I think, with another question is a type B lactic acidosis, when this is a natural, normal, evolutionary physiologic stress response, that you get mad beta receptor activation, whether it's from the patient's own physiologic stress or pharmacologically we do it. And that kind of lactic acidosis is not necessarily a bad thing and does not represent hypoperfusion because it's not resulting from an anaerobic metabolism mechanism. So that is also possible. The third kind that we're talking about with LR is when you're giving somebody sodium lactate. Now, it's really important to understand you are not giving them lactic acid. That is not what you're doing. You are giving them sodium lactate. And what you got to keep in mind here is that it's the lactate itself is not an acid. The lactate itself is actually a conjugate base, and when it pairs with a hydrogen, that's a lactic acid. But that's not what we're giving people. We are giving people lactate paired with the positively charged particle of sodium. Sodium lactate is what you're giving. And so when you give that, what's going to happen is, are you going to create a lactic acidosis? You are not. But what you are going to do is cause the lactate levels to go up. Because when we do the lactate test, that's what we're measuring, right? We're actually not measuring lactic acid. We are measuring lactate. And yeah, it's going to go up, absolutely. But what does that mean? Absolutely nothing. It doesn't mean you make the patient worse. The real question to me here is, one, okay, if I give a patient fluids and I'm making their shock worse by giving them fluids, they're in cardiogenic shock, they're in RV failure, I don't care what fluid I'm giving. That's going to make their lactic acidosis worse because I've just made their shock worse. If I think a patient will benefit from fluids, then, okay, I'm going to give them volume. What volume do I give them? It depends. And LR may make my lactate a little bit artificially high, but as opposed to normal saline, and you'll have to tell me if you want to go on a rant about the physiology of normal saline, but lactate ringers is not going to cause an acidosis. Normal saline will. Why? Because the strong ion difference of normal saline is 0. So if I'm going to give a bunch of fluids, I'd rather give something that's not going to actually cause an acidosis, and if it artificially, causes a marker that is equivocal to whether we should be using it to guide resuscitation in the first place, if it artificially goes up, I'm not that deeply concerned about it.
We have found a point of contention, so this will be interesting.
Here we go.
All right, let's see. So I think you've adroitly pointed out that lactic acidosis is a misnomer. But lactate acidosis is a true phenomenon. And lactate as an anion will generate the milieu of acidosis. If your lactate goes up, you are getting more acidotic on the metabolic side. So if you give sodium lactate and that lactate is not metabolized, it is in essence identical to normal saline in terms of its acid-base effects. So let me stop there and see if we disagree so far.
So from a net acid-base effect, and I don't know what the dose is. My guess, and I actually don't know, my question would be how much LR do you need to give to see a concomitant decrease in pH, to see a concomitant metabolic acidosis? And I would also guess it probably depends what's their liver function like, right? And how well are you or are you not metabolizing this? And I think for me, it also would depend what's their strong ion difference to begin with. Because if somebody already has a really, really, really poor, like a really, really low strong ion difference, then giving something that's going to make that worse. If they already have a non-GAP acidosis and I'm going to give something that's going to make that worse, I might not be that excited about it. If I'm actually doing okay as far as that goes, or maybe they've been vomiting like crazy, and maybe their strong ion difference is actually high, then maybe I'm actually wanting to give a little bit of normal saline to try and normalize that factor so it's not really giving me a delta delta that is actually masking my true acidosis. Do you know the sort of dose response here? Because you get different mechanisms, but the dose response between 1 liter of LR and 1 liter of NS, what it does to your pH?
So you very deftly shifted from physiology to clinical, which is a wise move because I agree with you on the clinical side. But let's parse out the physiology, and then I will happily answer your question, and then we can move to the clinical. So physiologically, you are indeed affecting the pH. Now, as to how much, that's where the clinical realm exists, and foreshadowing, not that much for the amount of saline or ringers we should actually be giving. But nevertheless, you're affecting the pH. Now, it might be on how many decimal places are you affecting it. Sure, I grant you that. But you are certainly making the patient more acidotic if you give lactated ringers to a patient who cannot metabolize that lactate because it sits around as an anion just like the chloride. So that it's inconsequential to the acid-base milieu whether that anion is a Cl or a lactate. So the alkalinizing effects or the neutrality effects of lactated ringers are predicate on either cellular uptake or metabolism of that lactate. So when that's not happening, which ostensibly is the case if you already have an elevated lactate at that moment, then it's no better. But it's also no worse. And where you get to the clinical side, Sarah, is that patient's anticipation is we're going to make them better, hopefully, in which case the chloride's going to stick around while unless their kidney function will take care of it, while the lactate, once they stop their inflammatory response, will get metabolized, and now they will be where we want them. And lactated ringers, when we really think about it, it's a neutral fluid. It's ideal for that. If you want to leave them the same, you give LR. If you want to make them acidotic, you give NS. And if you want to make them more basic, then you should give isotonic bicarb or maybe plasmolite, but that latter one's debatable. Physiologically, LR, yes, if they're not metabolizing, it makes it worse. And that's my guess is why the package insert says it. Now, your clinical points are absolutely dead on. First of all, giving a liter of LR is not going to significantly increase their lactate load. People think about lactate like they think about calcium. It's like, oh, it goes from 0 to 1. It's not like that. It's like you're making 100 millimoles of lactate and you're metabolizing hundreds millimoles of lactate every hour. And it's just the balance between that clearance and production is what your ostensible lactate is. If you add a liter of lactated ringers to the mix, it's like peeing in the ocean. It's not going to have any significant clinical effects. And since we anticipate the metabolism, it's certainly better than NS in a patient who's already acidotic. So how much does a liter give? Impossible to say because it all depends on their innate clearance. And you alluded to liver failure. Liver failure is one situation where it's probably not clever to give that patient LR because they're never going to get rid of it. So I'm just being hyperbolic here. Obviously, they're still going to get rid of it. Obviously, the kidneys and other organs still do metabolism of lactate. Do not write in, I was just using hyperbole. So giving that patient an isotonic bicarb in that case makes a little bit more sense if your ultimate goal is to leave them more alkalotic than they are right now. Now, most of the time with a lactate acidosis, you don't want to make them more alkalotic because eventually they're going to metabolize and then you're going to be left with a patient who is alkalotic. So LR makes a lot of sense. It's a neutral solution. Its effects on diluting albumin are perfectly balanced by its buffer base of the lactate. And what you get at the end of the day is a patient who is neutral. So I agree with you. I have no problem giving a patient with lactate acidosis lactated ringers as long as they eventually. Okay, so I'm cutting it off here for the free listeners. Now, there's another 35 minutes of question and answer that you are not getting because you are not a member of the EMCrit podcast. But you should be because it's inexpensive. You get CME, it's tax deductible, you report it to your group and get paid back. And all of a sudden, you never have to listen to commercials. You never have to listen to me talking to you like this. All of a sudden, you're just getting all of the resus and acute critical care goodness without having to have any of this crap that you don't want. So you should just do that. Just go to emcrit.org/join. Now, before you leave, I want you to hear Sarah's latest project in medical education. So I'm going to add that to the end of this. Listen to that because it's good. And we'll talk soon. Consider being a member, please. All right, Sarah, you've been so generous with your time. I love picking your brain. Tell us about the medical education project you're working on to finish us out, because it's so cool and so beautiful, and I really loved it. You were kind enough to give me access to it, and it's great. So tell the folks about it, please.
So it is called Rapid Sequence, and we started working on it, and it's a collaborative project between me and Ryan Ernst, who's an emergency physician. And the idea is we can sit here and talk about all of these resuscitation topics, and that's great. But what you really need to do to learn, and all the best learning experiences I've had, is I go, I do it, I fail, somebody's, this is what you did wrong, I do it again. Now, doing that with real patients, especially with high-risk things, where one, you just don't see them that often, and two, failing repeatedly, maybe not the cleverest idea. So we basically created a video game. And it's a game where you need to manage multiple patients at a time. It looks just like an EMR. You also have to deal with the people on your team bringing you data. And you don't have the multiple choice option, because as much as that would be nice, that's not sadly how it works in real life. You have an order set, you enter your orders, and then it's choose your own adventure. So if you do something that's maybe not so clever, the patient may code. And you have to deal with the consequences of your actions while you're being distracted. Because again, it would be nice if we could sit down in a quiet room and discuss a case for 6 hours with no interruptions, but yeah, I can't remember the last time that happened to me. So you have to manage multiple patients at the same time, then you get interrupted. You're trying to think about the vent for Mr. Jones, and a nurse comes up to you and is like, hey, can you just look at this EKG and make sure there's no STEMI? So we're both trying to create the clinical pathophysiology and cognitive problems you need to deal with, letting you try, fail, as well as some of the cognitive load things. And then at the end of every block, where you take care of a couple patients, at the end of each one, we sit and we teach the patient. So Ryan and I go back through and we try and bring both perspectives, the emergency medicine perspective and then the ICU perspective. And we're like, okay, this is Mr. Blake. So I'm looking at this and I'm seeing this. If you did this, he probably tried to die. What could we have done instead and why? And not just talk about the pathophysiology, but talk about the medical decision-making and the cognitive stuff and give people cognitive mental models, like framing the right question is an important one. So often in medicine, in real life, unlike on a test, you get somebody asking you a question and our response is to give the correct answer to the question that you were asked. And on a test, that is the correct thing to do. But in real life, that's not what you should do. Rather than give the correct answer to the question you were just asked, instead, you should ask if that was the right question in the first place and try and frame that right question. And so those are other things that we teach, that people from your team come to you and they're like, hey, you want to give this little old lady some Ativan for agitation? And your real question should be like, I've noticed her respiratory rate's 35 and her sat's a little low. Why can't she breathe, for example? So it's a game. You can sign up for it. There are 4 different blocks where you play a bunch of patients. We do some teaching. We try and cover some core ICU topics, but at a pretty high level, like acid-base, shock, respiratory failure. And so we'll include in the show notes the site, and then we can also include a promo code so that EMCrit listeners can get a discount on it as well.
That is very kind, and we will certainly put all that in there. Thank you for all you do, Sarah. Thank you for coming on, and hopefully this will not be the last time listeners hear from you.
Thank you so much, Scott. It was so awesome to be here.
Oh, do I hate that sound? I know you hate that sound, but that is the sound you hear at the end of a paid episode in which you only get partial content. And that's because you're not a member of EMCrit. You are not an EMCritter, which means you're not getting all of the up-to-date critical information to help your super sick patients. Whether you're in the ED, ICU, or the pre-hospital environment, EMCrit will help you take care of your patients better. It's cheap, it's tax deductible, or you could get it reimbursed on your CME, and you're part of something bigger than just this content. You're part of the team. And we're going to have so much incredible stuff coming out in the next year. New things, new episodes, new forms of education, and you're not going to want to miss out on it. And while there is a ton of foam, there's a bunch of stuff that is behind the paywall. So please, please consider joining. Just come to emcrit.org/join. It takes 2 seconds, and then you will never have to hear this message again. But more importantly, you will be getting the cutting-edge information to take care of your super sick patients. Scott Weingart for the EMCrit podcast saying bye-bye, and please come on over to emcrit.org/join.